Hello, everyone. Welcome to Understanding DM1 from genetics to care and everything in between. My name is Lucy Schiffman. I'm the Senior Manager of Community Engagement at the Myotonic Dystrophy Foundation. This session will run for just about 1 hour, first with a presentation with time for Q&A after. I'm excited to introduce Dr. Andrea Swenson, who is a neurologist specializing in neuromuscular diseases. She's the medical director at the University of Iowa Myotonic Dystrophy Clinic. In addition to providing comprehensive multidisciplinary care for patients with myotonic dystrophy, Dr. Swenson and her team actively participate in clinical trials for people with DM. So please join me in giving a warm welcome to Dr. Swenson.
Thank you, Lucy, and thank you for inviting me today. The presentation is on understanding DM1 from genetics to care and everything in between. So my disclosures are listed here. Today's learning objectives that we'll be going over: recognizing the prevalence of DM1 in the community, understand the signs and symptoms of DM1 and which body systems are affected, learn the genetics underlying DM1, and describe disease management, focusing on symptom control and enhanced quality of life. Myotonic dystrophy, let's break down the name. So myotonic comes from myotonia, which is a phenomenon given as an example in this video. This woman is letting her hand relax. We are taking the reflex hammer and tapping on her thumb muscle. And you can see what happens when we do that. The thumb muscle contracts and it stays there for a while and it slowly relaxes into the neutral position. Dystrophy, this refers to muscle weakness, and atrophy, which is loss of muscle or shrinking a muscle. So in this photo here, if you look at the arm, you can see there's some muscle loss in the arm, and looking down at the leg, there's muscle loss down in the lower part of the leg. There are two types of myotonic dystrophy. Type 1 is dystrophia myotonica type 1, or DM1, and type 2 is dystrophia myotonica type 2, or DM2. So we call it myotonic dystrophy, but the DM1 and DM2 terms have stuck. But you have to be careful because in the general healthcare system, if you refer to DM1 or DM2, a lot of times people think you're talking about diabetes. So just keep that in mind because a lot of people are going to think about that rather than myotonic dystrophy. Other terms you might hear: congenital myotonic dystrophy is type 1 that starts at birth or as an infant. You also might hear Steinert disease, which is named after Hans Steinert, who was the first to describe myotonic dystrophy back in 1909. And for type 2, you might hear proximal myotonic myopathy, or PROM, which is a term that is not used that often. So we are focusing on DM1. How common is it? It is the most common muscular dystrophy diagnosed in adults. 1 in 2,100 people have the DM1 genetic mutation in the US. So this amounts to about 150,000 people with DM1. So it is considered a rare disease, but it's a common rare disease. The prevalence is same in men and women, and we'll talk about that a little bit later on. Signs and symptoms of DM1. It is a multi-system disease. That means multiple organs within the body are affected by DM1. And this results in the many unique symptoms that people experience. Most people will notice their symptoms in their 20s or 30s. The symptoms do progress over time. Now, in this diagram of this human body, I know there's a lot listed there. There's a lot of symptoms, but it's important to keep in mind that not everyone experiences all of these symptoms. People will have varying degrees of symptom severity. So it's very important to keep that in mind as we're going through this. We're not going to cover absolutely everything, but we're going to target some of the areas where the main symptoms of DM1 are experienced. This includes the muscles. So skeletal muscle is the muscles of the face, the upper and lower extremities, so in your arms and legs. Cardiac muscle, that's the heart. And smooth muscle, which is within the esophagus, stomach, intestine, and bowels, or the GI tract. Skeletal muscle symptoms include myalgias, or muscle pain, which can feel like crampy muscles, achy muscles, and then the myotonia, which we saw in the video earlier. And this is a phenomenon where the muscle contracts and then really slowly relaxes back into that position. Oftentimes when you hear about myotonia, it may refer to grip myotonia, which is what this video is showing. So a person is being asked to squeeze the fingers, and then they're asked again to quickly let go of the fingers. And you can see what happens with that. So I'll play this video again. So they're squeezing tightly and being asked to release as quickly as they can. And you can see the fingers are very slow to open back up to the neutral position. So the grip myotonia is one thing that we talk a lot about, but myotonia can happen in other muscles as well. So I've included this video of a tongue being compressed down with the tongue depressor, and we're tapping on that. And you can see the middle of the tongue kind of squeezes together. That's also myotonia. So you can see how that kind of tightly comes together there. Weakness is part of the skeletal muscle involvement. With DM1, it's a distal weakness. So the weakness comes about with the hand and grip and also in the feet. So people might have a foot drop, which is not being able to pull the toes up towards the face. And this can be noticed with walking. Like sometimes people describe it feels like their feet are slapping on the ground, or they might be tripping on their toes. Over time, proximal muscles can get weak, and those are muscles that are around our shoulders to lift our arms above our heads, or our legs and hips standing up from a chair. With the facial muscle weakness, there can be weakness along the temples. So there can be muscle atrophy there that can give a sunken look here. And then ptosis, which is drooping of the eyelids, where the eyelids come over the eyeballs. There can be eye closure weakness. So trying to really squeeze the eyes tightly, that can be weak. And then also a weak cheek puff or smile. Respiratory muscles can be involved, which can manifest as feeling short of breath with exertion or exercise, and also feeling short of breath with lying flat. The heart is involved in myotonic dystrophy, and it's a very important organ that we want to make sure we focus on. I included this photo of a brochure that has been put together by Myotonic Dystrophy Support Group in the UK. It's a very nice brochure and easy to understand, and I've included photos from the brochure as well. The heart, what it does is it pumps blood with oxygen around the body to different organs throughout the body, like our kidneys, our liver, and so forth. And then it delivers blood with carbon dioxide back to the lungs so that that blood can exchange out the carbon dioxide for oxygen. The heart is very dependent on its rhythm. This rhythm needs to be very synchronized, and that allows for appropriate pumping of all four chambers of the heart. And this is controlled by the heart's own electrical system. So looking at this diagram, we've cut the heart in half, and you can see the four separate chambers here that all need to pump well together. In myotonic dystrophy, there can be arrhythmias, which are abnormal rhythms of the heart. Either the heart beats too slow or too fast or irregularly. There can also be block, where that electrical signal does not get through the entire heart. And oftentimes you will hear that referred to as conduction disease of the heart. When people have an arrhythmia, they may notice some symptoms. There can be some palpitations, which is feeling your heartbeats in your chest, or funny heartbeats there. If the amount of blood which gets pumped to the body may not be enough, and symptoms that can be felt with that is a lot of fatigue or difficulty exercising or feeling short of breath. Also, if not enough blood gets up to the brain when upright, it can result in passing out or having a blackout. And if anyone experiences these symptoms, they really need to talk with their doctor right away about this. Sometimes an arrhythmia can be present and there's no symptoms. And that's why it's so important to make sure to get heart testing to look for that. Our biggest concern is if an arrhythmia sets people up for sudden cardiac death. Now, cardiology, the field of cardiology has had so many advances recently as far as medications and devices that we have been able to reduce the risk of this significantly. But it also goes to show how important cardiac monitoring is. Patients can have dysphagia, which is difficulty swallowing, and there may be some choking with that. Aspiration can occur, which is when food or liquid gets into the lungs and can cause a pneumonia. People can have abdominal pain or bloating, constipation, diarrhea. There can be gallbladder and liver issues. Sometimes people have to have their gallbladder taken out. Everyone with DM1 will eventually develop cataracts. The cataracts form when calcium deposits in the lens of the eye and can cause a clouding of the lens. At the beginning of cataracts, there's not really any symptoms, but if cataracts are left there over time and not removed, they can result in vision impairment. This is another reason why it's important to get eyes checked, because there may not be symptoms that go along with the cataracts. Fatigue and sleep disorders. There is a lot to this topic in DM1. I'm just going over a few of those things, but there's definitely a lot to it. Daytime sleepiness and fatigue can be very common. People can experience hypersomnolence where they require more sleep. And sleep apnea can be a part of DM1, which results in poor quality sleep and snoring. And that therefore also contributes more to the daytime sleepiness. The effects on cognition or thinking in DM1 are variable. Some people don't notice any effects, while others may have intellectual disabilities that require individual learning plans for school or their occupation. Mood can be affected. Some people might experience an avoidant personality where they try to avoid situations where they may feel like they're being criticized or embarrassed. Apathy, which is lack of interest or initiative in different activities. And also with DM1, there is a higher risk of depression. Other systems that are involved: insulin resistance can lead to type 2 diabetes. Thyroid dysfunction can result in hyper or hypothyroidism, which can lead to increased or decreased level of thyroid hormones. There can be high triglycerides or high cholesterol. Primary hypogonadism can happen in men, which can lead to low testosterone, testicular atrophy, and can lead to infertility. And we always want to make sure we're being cautious with anesthesia. People with DM1 can undergo any surgery that is necessary for them, but we just want to make sure we're working with their surgeons and their anesthesiologists so that they know about DM1 and can implement precautions for the surgeries. There has been more research being done on looking at developing cancers within myotonic dystrophy. There does appear to be a higher risk of developing cancer, but so far, the recommendations are to stick with age-appropriate cancer screening through your primary care provider. What that means is screening that the general population will undergo, such as colonoscopies for colon cancer, mammograms for breast cancer, pelvic exam for ovarian and uterine cancers, testicular exam, skin exam, which can be done with a primary care provider or a dermatologist looking for skin cancers such as basal cell carcinoma or melanoma. Thyroid cancer is one of the cancers that may be slightly increased in myotonic dystrophy. And one of the things to consider would be getting a thyroid ultrasound to evaluate for that. Of course, we're always thinking about what other symptoms are going on and if those symptoms might indicate further screening for cancers. There was a study that asked around 1,000 patients with myotonic dystrophy what were their first symptoms? What were the first symptoms that they noticed with DM1? And 40% of people answered myotonia with grip, 20% first noticed arm weakness, 10% first noticed weakness feeling all over, and then 9% noticed leg weakness. So we talked a lot about the symptoms of myotonic dystrophy, and it's helpful to understand more of the DM1 genetics to explain why those symptoms are coming about. In clinic, we oftentimes get questions that are very similar to these from patients and their families. How does someone get DM1? Why do some family members have DM1 and others do not? And why are the symptoms of DM1 variable even within the same family? We'll get into these questions. So how does someone get DM1? To answer this question, we need to really do a deep dive into genetics. This is the study of how genes and traits are passed down from one generation to the next. DNA carries the blueprint for our body structure and instructions for our body organs to function properly. Each gene codes for a protein that is essential for a specific bodily function. And within all of us, we have 25,000 genes. The genes are on chromosomes, which are tightly condensed sequences of DNA. So within human cells, there are 23 pairs of chromosomes. So that's a total of 46 chromosomes. There's one set that's passed down from each parent. So if we look at this photo here, this is having all of the chromosomes laid out flat. There's 23 pairs of autosomal chromosomes, and those each have their own number up there. And then there's 2 sex chromosomes. And if someone has an XX of the sex chromosomes, they are female at birth. And if it's XY, they are male at birth. So looking at these chromosomes that are laid out, the one that we want to zero in on is number 19. And this is where DM1 starts. So looking at the big picture, it's helpful to think about the central dogma of biology. And this is the DNA, which gets transcribed into RNA, which then gets translated into protein. And the proteins are essential for our body organs to develop and function properly and be maintained over time. So this is a process that is ongoing all the time within our bodies. So what is up with this chromosome 19? So this is where the DMPK gene is located. So DMPK is dystrophia myotonica protein kinase. This gene plays an important role in our muscle, our heart, and our brain cells, but it's also located in other parts of our bodies, such as the thyroid, liver, pituitary gland, which has a lot to do with hormones in our body, the testes, eye. So it's located in many different parts of our body. And what happens to the DMPK gene in DM1? So genetic code in general is filled with series of letters, and these are nucleotide bases. In some genes, there is a section where a letter pattern repeats itself, and that is what happens in the DMPK gene. So if we kind of take this section here and blow it up, there are CTG repeats. Those are the letters that go with these repeats. Normally in the gene, there's going to be 5 to 34 of these repeats. So that's what we normally see. However, in DM1, these repeats get expanded or increased, and this could be anywhere from 50 to thousands of these repeats within the gene. What goes wrong when the repeats expand? So if we think back to that central dogma, we start out with the DNA. So in DM1, that DNA is going to have those additional repeats in there, and those get transcribed to RNA. So instead of the CTG, it's now a CUG for RNA, and there is a lot of it. And it is not destined to get translated into a protein. So one of the things in DM1 is the DMPK protein levels are half of where they should be. But the problem is really here. So all of this RNA is hanging out. And so an example of that is within a muscle fiber. This is a picture of a muscle cell. And this bright purple spot is that RNA that is just collecting there and clumping up. So when it clumps up in the cell, it disrupts the cell's normal function. Also, it traps important proteins. So one example is the protein muscleblind, which is a very important protein for things like muscle development. That gets stuck in these clumps and can't do the important things it needs to do. So this RNA that's stuck in these cells is disrupting a lot of functions that the cell relies on to function properly. So it's going to affect chloride channels, which causes the myotonia, affecting the insulin receptor, which can lead to diabetes, affecting the calcium channel, which can lead to a myopathy, which is muscle weakness. And then also it can affect the sodium channel, which causes the arrhythmias in the heart. So this process is leading to the multi-system disease that we see clinically. And this is also an area where there's a lot of research being done for treatments to see if there's something we can do to prevent this process. Why do family members have DM1 and others do not? DM1 is inherited through an autosomal dominant pattern. That means that to get the disease, there has to be one mutation. So one copy of a mutated gene passed down from one parent can cause DM1 in a child. Each child has a 50-50 chance of inheriting the gene mutation, and a parent with DM1 may pass it on to none of their children, a few of their children, or all of their children. So sometimes in clinic, we get questions about this idea of 50-50, thinking it might be half the kids they have it and half the kids they don't, but it's actually each child has that 50-50 chance of having it. And why are the symptoms of DM1 variable even within the same family? One of the concepts that contributes to this is called anticipation. And this means that a parent's number of repeats will be less than what their child has. So in this picture, you can see a parent with DM1 and the number of repeats they have, and it's increased by quite a lot in the child. So without DM1, the repeats are stable. So this is an example of a parent who has 10 repeats. So they do not have DM1, and they will pass on 10 repeats to their child. However, in DM1, those repeats are unstable. So if a parent has 50 or more repeats, then their child's repeat size is going to be more than that. So looking at this a little bit further, if we take the DMPK gene and think about the repeat size. So if the repeats are 5 to 34, that is not going to cause DM1. If the repeats are bumped up a little bit, like into 35 and 49, that is not going to cause DM1 in that person. But that person does have the possibility of passing on more repeats to their children, and those repeats could be in a range that cause DM1. So if we look at even more repeats, if we go out to the end over here, greater than 1,000, that's where people develop congenital onset. And that was when symptoms are present at birth or within the first month or so. And then if we look at 50 to 100 repeats, that is going to cause mild disease or disease starting in 40s and older. Childhood onset would be greater than 800. Classic adult onset, ages 20 to 40, is going to be 50 to 1,000. But what's interesting, if you look at these numbers, there's quite a bit of overlap. So some people may have a repeat size of 500 and have less severe disease compared to another person who has a repeat size of 500. So there's a lot of variability. So hold on to that thought. We'll get back to that in a moment here. So this is a photo from Andy Engel's myology book, and it's describing anticipation within a family. So the grandmother has mild symptoms. The mother, you can see in the photo, has some facial weakness, and the child looks like they have facial weakness and maybe having some trouble holding their neck up, so maybe some neck weakness, and they have congenital myotonic dystrophy. These are not the repeat sizes from this photo. I just use these as examples, but the grandmother could have 82 repeats. The mother could have 500. The childhood could have more than 1,000, just to give you an example of what that might look like in a family. Another phenomenon that's going on is that the tissues within a person's body may have different numbers of repeats. So for example, the muscle tissue will have more repeats than the blood tissue. And so that can be causing some of the differences that we see in people's symptoms. If one body organ has more repeats than another, they might have more symptoms just in that area. Also, the cells within a tissue may have different repeat sizes. So this is a biopsy from muscle, and each one of these segments is a muscle cell. So this is just to give you an example what that could look like. Each of the cells could have a different number of repeats, even within the same tissue. And also, my arrow's in the wrong place there, but as time goes on, the repeats increase with age. So in the blood, with time, the repeats are fairly stable. However, in the muscle, if we measure repeats in the muscle, those do increase with age. So these are some things that probably have an impact on why we see so much variability between person to person with DM1. But another thing to add to that is maybe repeats don't tell the whole story. Like we saw in that one diagram with so much overlap between the age of onset. There could be other genes in the body that may be getting involved, and maybe those genes have an impact on what the DMPK mutation does. There also can be environmental factors, so things such as where we live, what are our activity levels, the things that we eat, other medical problems that we have. Those can all have an impact on what happens in DM1. So to get back to our questions, how does someone get DM1? It's due to the expanded repeats in the DMPK gene, leading to that RNA toxicity. Why do some family members have DM1 and others do not? It's autosomal dominant inheritance. So a child will have a 50-50 chance of getting the gene mutation. Why are the symptoms of DM1 variable even within the same family? So that's due to phenomenon such as anticipation and the repeat size that a person has, as well as somatic mosaicism and other factors. All right, so we're getting into the home stretch, DM1 management. An important first step is to really build your team. This is a photo from our University of Iowa Myotonic Dystrophy Multidisciplinary Clinic. We have our neurologists and our therapists, pharmacists, nurses, a pretty big team. So it's really important to get that together. The main players in your management will be neurologists, and the neurologist is really directing the care management specific to DM1. It's also important to have a primary care provider. Primary care providers are experts in diseases that are common, but there's so many rare diseases out there that it's hard to learn about all of them and really become experts in them. So many primary care providers have not had a lot of experience with DM1, and sometimes we hear from patients that they may be the only patient with DM1 that their primary care provider follows. But it is really helpful to establish care with one to help manage other medical issues and to just take care of overall health. You want to establish care with providers that you trust and know that they're interested in learning more about DM1 and working closely with you. I also throw up the dentist here because it's important to keep up dental health with checkups and cleaning. So I have a list here of physician team members. These are the team members that we work with in our clinic, and I'll just go over what each of them does. So the neurologist focuses on the brain and muscles and diagnoses DM1, manages the overall care plan for DM1, and treats symptoms that might come along with myalgias or myotonia. Primary care provider is excellent for overall health, at least yearly checkups for age appropriate health screening. They also can be very helpful in the cancer screening, as well as managing GI symptoms such as diarrhea and constipation. A cardiologist who focuses on the heart, and some of the tests that they will have done are EKGs, which look at the heart rhythm. There are also other types of monitoring that go on for longer that can look at the heart rhythm as well. Doing echocardiograms, which look at heart structure and how the heart is pumping. And they also can work through whether people need a pacemaker or not, or when is the right time for them to look into those interventions. An ophthalmologist, an eye doctor who can screen and remove cataracts. a sleep specialist or pulmonologist who can help with the sleep symptoms as well as any breathing issues or shortness of breath. So, focusing on sleep hygiene. Some patients use an apparatus called non invasive ventilation, which can help with sleep apnea as well as any respiratory muscle weakness. Other things that they can help out with is if people need stimulant medications for daytime sleepiness. This is a list of our therapy team members that we have in clinic. Our physical therapist will evaluate people's strength and watch them walk and come up with exercise and activity plans for them, as well as addressing any bracing or wheelchair needs. Occupational therapists focus on hand function. They are really helpful in working through grip myotonia, which can sometimes be interfering with people's work or their activities of daily living, and they have a lot of strategies to help overcome that. Our respiratory therapists will measure people's breathing in clinic so we can see where they're at with that. And then a speech therapist who can recommend foods that are easy to swallow if people are having trouble swallowing. Sometimes people can have changes in their speech, and the speech therapist can assess that and make recommendations. Our genetic counselor who can explain genetic testing results as well as identifying any family members who may be at risk for DM1 and family planning. A mental health counselor who provides emotional support, focusing on well being, as well as providing coping strategies. And a social worker who is great at helping out with any accommodations that are needed in work or in school, helping fill out disability, and then also setting up any healthcare resources that they might need in the home. Patients often ask us, what can I expect with this disease, or what can I do about it? Also, questions come up, when will I need to use a walker or start using a wheelchair? So the University of Rochester has a registry for patients with DM1, and they send out surveys on a yearly basis. And part of that survey was to assess at what age do people need a certain intervention or a piece of equipment. So this was using the age 60 as a benchmark for that. And as far as equipment like an ankle brace, 25% of people were using those by age 60, a walker, 35%, and a wheelchair, 20%. For getting a pacemaker implanted, 24% of people had that by age 60, and 30% people were using non-invasive ventilation. So what are things that you can do? I really encourage you to get to know DM1. Build your healthcare team. We at the University of Iowa are very lucky to have a dedicated myotonic dystrophy clinic, and I know that's not available everywhere, but working with your neurologist and your primary care provider, they can help you build these teams wherever you are. I encourage you to identify your goals and make sure you relay those to your healthcare team. So sometimes I find that healthcare providers may assume that you have certain goals that you want to achieve with your healthcare, and it may be entirely different than what you're thinking. So it's really important to think about what you want to get out of your healthcare team and make sure you relay that to them. One of my colleagues in our department really likes to talk about NESS, nutrition, exercise, sleep, and stress. So I think this is a really important concept, no matter what disease we're talking about, focusing on your overall health. And by doing that, that can also help DM1. And reach out for support. DM1 is a rare disease, and sometimes that can feel lonely and isolating, but there is a lot of support, especially through groups like Myotonic Dystrophy Foundation. They have a lot of resources, a really great website, a lot of information on there for both people with DM1 as well as their healthcare providers. So definitely encourage you to reach out. And with that, thank you so much for attending, and we'll open it up for questions.
I have two questions actually. Maybe they go too far for this session. You spoke about the MBNL protein. Most current and upcoming trials are looking to release those MBNLs to get into the muscles. Why don't we just inject MBNL?
Yes, that is a great thought, but it still doesn't get at the underlying process. So that is still going on. Even if you're adding more to it, I don't think we could add enough that it would overcome the underlying process.
I had a question about cataracts. You mentioned that I know cataracts are common with DM1, but you mentioned there's a 100% chance of someone having cataracts. Is that correct?
Yeah. Yep. At some point in their life. Yeah. So we think of them as young onset. And so in the case of cataracts, that would be below the age of 55. And it can happen at any time within that age group. And we've had people who've been older than that who've had cataracts, but at some point they happen.
Thank you so much for sharing the research about what you can expect. That was more information than I've ever been able to get from a medical professional. They always say so variable, no one can say exactly what you should expect. And so that was very illuminating and that research very helpful. I'm curious if there's anything you can say without further research about just how that compares to the base rate of the general population. So those likelihoods of needing walk or likelihoods of needing external supports and things like that.
Yeah. So thinking about the general population and what would necessitate using a walker, probably the things that we see for that would be orthopedic, like arthritis, back problems. And I think most people would fall in that category would be older than what we're seeing with these numbers. So probably older than 60. And again, I'm just thinking about things like arthritis that are probably going to be the more common things to necessitate walker, wheelchair. And that would definitely be an older age group. Yeah.
So if a parent does not pass DM1 to the kids, to clarify, does that mean it can skip a generation or does it stop there?
So if the child does not get the mutation, the child cannot pass it on. It would not skip a generation. It would stop at that child.
We have a question from Zoom. Is it necessary to medicate to lower cholesterol and triglyceride levels, or will the levels remain elevated just because that's part of DM?
That medications can treat that. One thing with that, cholesterol medications are good, and it's important to treat cholesterol from a cardiac standpoint. We do know with research in stroke prevention, heart attack prevention, medications for cholesterol are very important. But that being said, there are some that can have some muscle side effects. And that's where it can be a little bit tricky in some of the medications, such as statins, which are used to lower cholesterol. And that would necessitate discussions with your primary care provider, your neurologist, to figure out what's the right cholesterol medicine. But yes, that can be treated.
In the repeats where it says the premutation, 35 to 49, is that kind of like laying dormant? And would it show up on a genetic test as having myotonic, carrying it at least? Are you a carrier, I guess what I'm saying, but you're not expressing it? Is that a possibility?
That's a good way to think of it. Yeah. So in that repeat size for that person who has it, they're not going to have symptoms of DM1. But where that comes into play is if kids are born and have myotonic dystrophy. The situations where we might see that is for a baby who's born and develops myotonic dystrophy, but neither parent had any symptoms of it. And if we're able to do genetic testing that can pick up those numbers, then we could see that in the parent, and it would have never been discovered until the child was born. That's a great question. I don't know if we would call that a positive test. I'm looking at my genetic counselor over here. They would say indeterminate, maybe, or premutation.
So yeah, it's a tricky question. I don't know if you would clearly put it in the category of clearly positive or clearly negative. I think it is somewhere technically in between those two things.
Hello. Is there a general anesthesia that is recommended for someone who's affected with MD1 or MD2 when doing a voluntary or outpatient surgery, such as a pacemaker? Because most doctors don't know that you can't be under anesthesia or you have to be watched. Or so I was just wondering if there's a certain type that was recommended for people affected with this disease.
Yeah, so this question is about anesthesia. So there's not a type of anesthesia that would cause a lot of problems. So it depends on the surgery. If the surgery can be done where someone would not need general anesthesia, and general anesthesia means really heavily sedating someone, putting them to sleep so much to the point that they're not awake enough to breathe on their own, where they have to have a breathing tube put in and be put on a breathing machine for the surgery. Also, part of that is paralyzing the muscles. So it's a combination of two medications to really put people to sleep and to paralyze their muscles. And they're on a breathing machine during that surgery. So this is generally for bigger surgeries. If someone had to have, for example, open heart surgery or an abdominal surgery where they're going in inside the abdomen, that's generally where something like general anesthesia is used. There are not any medications with that would cause problems, although there is one type of medication called succinylcholine, which we recommend avoiding that one. And the MDF website has a great section. Yeah, it has a great section on all things about anesthesia on there. The problems are more after the surgery's done and trying to get people off of the breathing machine. So when the muscles at baseline are weaker, it can just take longer to wake up from that surgery, and it may even take longer to start breathing on your own. So an example might be if someone has a surgery, usually that day we take them off of the breathing tube and they're breathing on their own and ready to go. But maybe with DM1, they might be needing another night on the breathing machine, and maybe the next day they're stronger to come off of it. And it's not a bad thing. It's just that we need extra monitoring and need to make sure people know about that. Now, with some surgeries, you can do the general anesthesia or you can do something called regional anesthesia. So an example of that might be an orthopedic surgery in the hand or the leg, where they can focus the anesthesia more on that body part and they don't have to knock people out completely. So for people who have DM1, the regional anesthesia might be a better choice because you don't have to get on the breathing machine and go through the paralyzing and all of that. Yeah.
And I will just add to that. Not only do we have an amazing website on anesthesia resources, but we do have all of those resources printed in the exhibitors hall. We have our quick reference guides for your clinicians, the anesthesia guidelines, as well as community-centered anesthesia guidelines that can help you understand it better so you can better advocate with your clinicians on how to best use anesthesia.
Hello. Thank you. I just have a two-part question. Is there any research that indicates certain behaviors that someone with DM1 can participate in to slow the growth of some of the major symptoms? For example, you mentioned apathy and depression, loss of interest. Is there anything that's been proven to getting them involved in something to prevent that? And my second part, what are the opposite end? What are some behaviors to watch out for? If someone that you're caretaking is starting to slip into some things that may not be good, may actually make the symptoms worse.
Yeah. So regarding behavior symptoms and things to watch out for that, we do have a mental health counselor who works with us, and she meets with patients and makes assessments to check in on them and see how things are going. Types of therapies that can be helpful are those like cognitive behavioral therapy, which is working with a therapist to look at the behaviors, identify them, and figure out strategies to manage. Things to look out for. We talk a lot with families about apathy, which is the decreased interest or initiation in activities. And this can affect people in a way that they maybe aren't doing a lot during the day. We have some families tell us that their loved one will watch TV a lot or kind of sit by themselves, and they wonder why aren't they interested? Why can't I get them to do anything? And that is part of the disease. So watching out for those types of behaviors and looking for things that people can get interested in, what are activities that they like, and trying to introduce those more. It can be challenging and can really affect how people's day-to-day life looks with the apathy. But it is working a lot with the patients and their families and thinking about what are things that they enjoy and how can we get them more involved in that.
And MDF has an amazing mental health handbook that's also available at our resource table in the exhibitors hall that talks about finding a good therapist and other opportunities and resources that you can for those things. Yeah.
To add to the anesthesia thing you were talking about, my son, myotonic dystrophy, DM1, with his surgery, the myotonia kept the tube from coming out. So I just wanted to add that if somebody that might be a thing on top of the
Yes.
anesthesia would be if they have the myotonia in the throat, then that takes longer too.
Yep. Yeah, absolutely. Thank you.
Thank you. I have two questions. One, is there anything out there whether a major surgery has an impact on the acceleration of the disease? If it's elective, should you avoid it for that, or childbirth would do the same? And then the second one is exercise.
Yeah.
When is it too much exercise, and where's the sweet spot where you're actually either developing or maintaining the muscle and not damaging it?
So for muscle disease in general, going under certain stressors, such as a major surgery or childbirth, may impact their strength after the event. And we do see that, and people do comment about that. And sometimes, depending on the surgery, their recovery can take longer. And we have had people experience a surgery feeling weak, and they maybe feel like they never get back to where they were before. When it comes to surgery, I think for anybody, if it's a question about elective surgery, you really have to weigh your risks and benefits and talk with your care providers to see if it's the right thing for you to do. And we work through a lot of these questions with our patients, and we make sure to include their primary care providers, their surgeons, just making sure that surgery makes sense. Your question about exercise, we work on this a lot in clinic with our physical therapist. Exercise is good. One of the things I think a lot about is what happens to a muscle, any muscle, when it's not active. And muscle atrophy and deconditioning can set in pretty quickly, just in muscles in general. So with exercise, we're thinking about trying to prevent that deconditioning, because deconditioning can just make you feel weaker. And so with exercise, it's important to do something that feels good and is safe. We don't want to set people up in an exercise situation where they might fall, break a hip, and then that is a major setback. And then also exercise that is something that people are going to do that they enjoy. Want to make sure that it includes that as well. As far as when to recognize that you're overdoing it, one thing I really appreciate about our physical therapists is they are very tuned into this, and they talk a lot about energy and energy levels. So at any given day, we have a certain amount of energy that any of us could use. And you want to think about what activity do I want to use that energy on? If too much of that energy goes towards exercise, it may be that the next couple hours after exercise, you can't do anything. You're just too tuckered out. And if that's happening, then our physical therapists will tell people to back off on their exercise. So you really have to pay attention to your body. Exercise is good. You don't want to do too much where you're just getting fatigued for the rest of the day, because you want to keep up with your other activities too. But it is an important piece of DM1 management.
So I have one question related to low blood pressure. Is that something that DM1 patients can expect to experience, low blood pressure or drops in blood pressure?
So potentially, It's not one of the more common symptoms that we talk about, but we can see that for varieties of reasons. Some examples, we've seen that if people are having trouble keeping up with their fluid intake, if they're not drinking enough, or if they're choking on liquids, they might not be drinking enough. So we can see some low blood pressure with that. If they're having cardiac issues, the blood pressure can be tied into that too. Also, some of the medications that we use to treat arrhythmias also lower blood pressure. So that's not the disease, that's us doing that with medications, but that can also be a symptom that people experience.
Excellent. Thank you so much, Dr. Swenson.